Important topic today, delirium. Delighted to be with you all, and thank you all for being with us today. I'm a geriatric psychiatrist. I work at Baycrest in Toronto, and these are my disclosures. So really just to say that I have grant support from a number of different, mostly federal agencies, and honoraire from Health Canada and Public Health Agency of Canada. So nothing, no major conflicts with regard to today's presentations, nothing from pharmaceutical industries. The funding for this program is through the Public Health Agency of Canada through a larger grant that the CCSMH, Canadian Coalition for Seniors Mental Health, has obtained. We do our very best to be evidence-based when there is evidence, and this just says that. Learning objectives. So I'm hoping that by the end of the session, you'll be able to list some key precipitating factors for delirium, select some appropriate screening tools, be able to describe some strategies to prevent delirium, and be aware of the association between COVID-19 and delirium, and then be able to outline some management approaches. So that's quite a bit. I'll move fast, but you have my slides. So what is delirium? An acute disorder of cognition. It's really brain failure. We don't usually use that term, but we have cardiac failure. This is really brain failure. The brain's not working properly. So in many ways, it's not that well understood, but it's common, it's serious, it's costly and often under-recognized, and it's certainly associated with very high mortality rates. So, it's often in many circumstances, it's considered to be an urgent or emergency situation. So this is the DSM-5 criteria for delirium. So the first thing is a disturbance in attention and awareness. So that's really critical. In most cases, this is what we see. In fact, you have to have that. It's criterion A. It develops over a short period. It represents a change from baseline. It tends to fluctuate in severity during the course of the day. And then there should be one additional disturbance in cognition, but that could be in just about any area: memory, disorientation, language, visuospatial ability, or perception. And then it's not accounted for by something else, such as coma, which is interesting. But this is interesting. There's evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or exposure to a toxin, or due to multiple etiologies. So there should be some evidence, although sometimes it's hard to find. Sometimes it's like being a detective trying to figure out what's going on. So here are some of the sort of main features. So disturbance of cognition, psychomotor disturbance, so we often have agitation or a kind of withdrawal state. Emotional dysregulation, so there's often irritability or anger or fear or anxiety. We mentioned the circadian rhythm disturbance, as well as impairments of consciousness and attention. This is from a paper by Maldonado, an excellent paper from 2017. As is this image here. So basically, in this paper, they describe there are precipitating factors that cause this end acute brain failure. You have baseline cognitive and physical functioning, but then you can have minor symptoms that would be considered a subsyndromal type. And then you either can have hypoactive, where the person's very withdrawn and quiet, or hyperactive, where they're quite agitated and more obviously disturbed. And when we think of delirium, we often think of that hyperactive type. Or you can get a combination of the two. At the extreme ends, you could have what's called catatonic type of delirium, where the person's completely slowed down and unresponsive, or a very excited, catatonic excitement, it's called. We'll talk about the outcomes later. So predisposing factors are things that make it more likely that you could become delirious. So increasing age, dementia, or any kind of cognitive impairment, history of delirium or depression, and then generally impaired function or disability, sensory impairment, dehydration, malnutrition, drugs, and coexisting conditions, really any severe medical illness. So that's predisposing. The things that actually precipitate it, really contributing to the actual syndrome itself. Number one, drugs, particularly psychotropic drugs, narcotics, anticholinergics, then withdrawal from things like alcohol or benzodiazepines, and then infections, surgery. We see a lot in post-surgical states, physiological abnormalities such as abnormal sodium, organ failure, it could be hypoxia, for example, and then things that can also be a factor would be environmental changes. So actually being in an intensive care unit, being in restraints, catheterization, these all can contribute, as well as things like sleep deprivation, stress, and inadequate pain control. So here's a case example. So an 81-year-old retired school teacher in a general hospital. She's had surgery for a hip fracture. She lives alone. Her husband had died 2 years earlier. 2 days post-operatively, there's a sudden onset of agitation, disorientation, visual and tactile hallucinations. She feels like there's bugs crawling on her skin. Paranoid delusions, day-night reversal. She wants to leave the hospital. She's already been given an injection of Haldol. She was put in restraints briefly. Medical history of hypothyroidism, mild hypertension, urinary incontinence, high cholesterol, cholecystectomy. These are the medications she's on. So for thyroid, hydrochlorothiazide, oxybutynin, which is for urinary incontinence, aspirin, torvastatin, and she takes occasional Gravol for sleep. Apparently she uses her daughter's Zopiclone on occasion. She's restless, distractible, tremulous. Mini mental score is 18. Her clock is impaired. She has mildly elevated liver function tests. So I'm wondering if in the chat you could name one likely cause for her delirium. There's no correct answer here. It's just, what do you think? What could be causing the delirium? Great, lots of great answers here. Oh, somebody hit on the right answer there. That's great. Very good. And the important thing to note here is there are a lot of possible causes, right? So how do you figure all of this out? Thank you. This is great. So, thank you. Yeah, so her family reports that Mrs. A enjoys several large martinis every evening before dinner. She's drinking more since the death of her husband 2 years ago, and she's becoming somewhat forgetful, and she's had a number of falls in recent months. So now in the chat, if you could put down what do you think is now the most likely cause of her delirium? Yes, indeed. So absolutely. Thank you. Yeah. So and without that bit of information, that history, you might not actually know what the cause is at all, right? So critical question, right? That's great. It's an image of from Dali. I think this everything's very strange for a person experiencing delirium and disorientation, of course. So this is the epidemiology. So it's not that common in the community, but it's very common in the emergency room, and more likely if you're hospitalized in post-operative states. You think it might not be certainly as common in long-term care, and there haven't been many studies, but there have been a few studies suggesting that it's not uncommon at all. Then there are extremely high rates in certain populations, such as in palliative care and in intensive care units in general. What about the overlap between delirium, dementia, and depression, the 3 Ds? This is from the RNAO, the Nurses Association of Ontario. It's quite a nice diagram here that explains some of the differences, but the ones with the stars there particularly. So again, with delirium, it's an acute onset. So the other 2 generally are not acute onset. And there's a bunch, and the alertness level is different. So, you may be lethargic or hyper alert with delirium, and attention, right? The attentional deficit is extreme in delirium. Of course, people with dementia may have some difficulty with attention, or even people who are depressed may not focus that well, but this is much more pronounced in delirium. And then, this is also comparing the 3Ds here, but perception. So you often get hallucinations, visual hallucinations in particular, as well as delusions. Now you can get those in dementia as well, for sure. We'll hear about that in one of the cases today. And hallucinations are relatively rare in depression. So what's actually going on? What do we understand about the pathophysiology? So again, from that paper by Maldonado, so the brain is aging, there's neuroinflammation, oxidative stress, changes in neuroendocrine function, circadian dysregulation, neurotransmitter changes, and disconnectivity between networks in the brain. So these are all different ways of looking at what may be going on in the brain. So a lot's happening. And this is a slide that actually looks at some of the different neurotransmitter changes that we believe are happening in some cases. Cholinergic changes, anticholinergic in the red there, inhibition of the acetylcholine system, the anticholinergic activity. We know for sure that that is very relevant in some cases, but not all. And when you have too much anticholinergic activity, this is the clinical picture, that you're hot as a hair, dry as a bone, blind as a bat, because your vision can be impaired. You're hot and red as a beet and mad as a hatter because you're delirious. So that's a description. So yeah, so although it sounds like that's the delirium is very obvious when you see it, but it is actually often unrecognized by nurses and physicians in hospital settings. And so one more question: why do you think that might be? Can you just type in the chat why it could be? Put down one reason why you think it might be unrecognized, why it might be missed. Yes. Good answers here. Wow. It's fluctuating. Exactly. Yes. You might not have a good baseline. Confusion with dementia. Everyone's too busy. Yes. Lack of education. Excellent. Great answers. Thank you. And so, yes, here's some of my answers that overlap with your answers, which is great. So fluctuating course, overlap with dementia, lack of formal cognitive assessment, baseline, and neglecting to determine the acuity, underappreciation of its importance and consequences, and general ageism. Isn't everyone that's all confused? So the Canadian guidelines were initially released many years ago and then updated in 2014. There's also a separate guideline that was created on delirium at the end of life. So you can get all these from our website, ccsmh.ca. Screening instruments. So these are some of the recommendations from our guidelines. So the CAM, the confusion assessment method, is strongly recommended in acute medical and surgical wards. And in the emergency room, there are some variations on the CAM. There's something called the delirium symptom interview, which could be additionally recommended in complex cases. And then there's a separate instrument that's recommended for monitoring symptoms of alcohol withdrawal. This is the CAM. So you have to have an acute onset and fluctuating course, inattention, and then either disorganized thinking or altered level of consciousness. And if you have that, you're considered CAM positive. And what does that mean? It means that there might be delirium, and you should take a closer look at what's going on. And really you either want to rule out delirium, or if there is delirium, then you've got to investigate and find out what is going on. Tools like the MoCA, this instrument could be very difficult for someone with delirium. They may have a lot of difficulty focusing and concentrating, but the attentional tasks in here could be very helpful, like the list of letters that you have to tap, or just counting backwards from 100 could be a good test, again, to test attention. It's an easy test. It should be easy for everybody, right? But if you're not focusing or able to attend, that would be a hard test. So the outcomes for delirium are not great, because there's definitely an increased mortality rate, increased length of stay, increased risk of institutionalization, and there may be persistent cognitive impairment. So this is from a recent systematic review and meta-analysis, and in this case, you're looking at people who had delirium versus people who so the chances of developing delirium, developing dementia in the long run after having an episode of delirium were, in this study, almost 12 times as likely as a matched group that did not have delirium. And these individuals did not have pre-existing dementia, so that's pretty scary. So, and one thing we know is that some people, the classic situation is somebody recovers quickly from their delirium. Certainly with younger people, that's most common. But with older adults, for whatever reason, sometimes the person never fully recovers and they have ongoing cognitive difficulties. And as we just discussed, they're much more likely to develop dementia later. And there's all sorts of theories about this, but it could be that the illness itself, whatever's causing the delirium, is causing changes in the brain that may be, activating existing problems or causing new problems. So we have to be cautious in terms of recovery, in terms of prognosticating recovery from delirium. Still, the majority of older people do recover pretty well. Just to mention, we're escaping from COVID-19, it looks like, it feels like, but that's been a critical issue during the pandemic. A lot of people who've had more serious illness with COVID-19 have become delirious. And there's an initial paper from Wuhan in China looking at this issue. Another paper from France showing a lot of the classic signs of delirium in individuals who were hospitalized with COVID. And there's lots of reasons why that might be the case listed here. I'm not going to go through them, but this is an amazing paper. If you're interested in this issue by Kotfis, this was a paper that described the whole increased risk of delirium with COVID and then how to care for people in the light of what was going on with the pandemic. And the red boxes there demonstrate an understanding of how difficult the circumstances were for patients, families, and professionals themselves, with burnout of staff and so on. So it's really just pointing out all of the challenges in caring for people who had COVID, but also had delirium. We've got one poll question for you today, and I think Farah is going to be able to put that up for us. Yeah, how often can delirium be prevented in hospitals?
So are you going to put that up for us? Farah's trying very hard. I can see the expression on her face. Okay, no one is watching. Take your time.
Yeah, we can show it now.
Do you see it now? Result?
Yeah, you can share the results, yeah. Can people see the results? I'm not sure.
Yes.
You can, great. Okay, so well, it's interesting. You're a very optimistic group there with the 90, 65, and 50 sort of leading the way. So it's not quite that good, but it is good in the sense that now, so many of you may have heard of this program. It's the HELP program. It originated from Yale, and Sharon Inoue, who's really the guru, I would say, of delirium management and care. In the help model, these are all things you can do in people at risk of delirium, stimulating the mind socially, getting people activated as soon as possible, perhaps after surgery, sleeping well, but not with drugs, seeing and hearing, making sure people have their hearing aids and glasses, staying hydrated and eating well. And volunteers in hospitals that adopt this program help to make all these things happen. Here's a poster for the program. And this was the original study that Inoue did in Yale. And what you see here is that the usual care group developed delirium in 15% of the time versus the intervention group, 9.9, so say 10% of the time. So that's a reduction by about a third. Still pretty impressive. There's no drugs that have been shown to be of use in preventing delirium. A lot of studies and hope for certain drugs like cholinergic drugs. Although this was interesting, this systematic review of melatonin or Ramelteon, which is a melatonergic drug, it actually suggested that the odds ratio of these particular studies when added together was 0.63. So an actually quite significant reduction using a meta-analysis. Although the largest trial, the one with the second from the top there, is which had by far the largest number of patients, was actually a negative trial. So how do we care for people with delirium? So got to investigate. This is the recommended blood tests and other tests that are necessary to rule out any underlying illnesses. Non-pharmacological approaches. So you got to correct whatever's causing. That's why you need to be Sherlock Holmes and figure out exactly what is causing the delirium and then try and stabilize that, treat that. Whole pile of other non-pharmacological treatments, so keep the person safe. Environmental strategies listed here. So you don't want too much stimulation nor too little. You need good lighting. You need to use clocks and calendars and whiteboards, and avoid room changes, use familiar objects, family if possible, and avoid putting delirious patients in the same room together, which is a great recommendation. When it comes to medications in red, we only want to use these medications for those in significant distress due to agitation or psychotic symptoms in order to carry out essential investigations or treatment and or to prevent older delirious persons from endangering themselves or others. We would not normally use medications, psychotropics, for hypoactive delirium. If you have to use something, the best evidence is for antipsychotics. Again, we don't like using them. We would use them in very small amounts, except if it's in a withdrawal state with alcohol or benzodiazepines, in which case benzodiazepines are actually the treatment of choice. And there are options. Haloperidol is still used, has some advantages. Or an atypical antipsychotic like risperidone, or in someone with Parkinson's disease or Lewy body dementia, we would prefer quetiapine. Very, very low doses of haloperidol. This may not always be practically possible, but a cardiogram is recommended if possible because there are actual serious risks if the QTC interval is too great. And again, benzodiazepines for withdrawal states, and we tend to avoid them. Families often are really in the dark. They don't know what's going on. They're scared, they're frightened, not to mention the person themselves. These are some booklets that explain to families what may be going on here. The two on the left are from CCSMH, including one in Punjabi here, and we also have them in Chinese, and the booklet on the right is from Scotland. It's very good. So final key points. So delirium represents acute brain failure. There are multiple precipitating factors to consider. The use of screening tools is optimal, like the CAM. COVID is associated with delirium. Very high risk of developing dementia. Preventative strategies can reduce the incidence of delirium. Optimal treatment of underlying causes is critical, and the management includes non-pharmacological, environmental approaches, with the use of psychotropic meds being reserved for those in severe distress or in danger of harming themselves or others. There's a lot of territory there I've covered quickly, but I'd be happy to take any questions.
Wonderful. Thank you so much, David. Great presentation, really focused on a lot of the key points. And